Welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS learning that you can fit into your busy life. And today I'm talking about vaccine hesitancy, because already this year we've read a lot in the news about outbreaks of infectious diseases like measles and whooping cough, and it seems that this is in part because of declining rates of vaccine uptake. What's more, we know that there are inequalities in vaccine uptake associated with ethnicity, deprivation, and geography. So Dr Farzana Hussain is a GP in East London, and I've invited Dr Hussain onto our podcast today because during the COVID pandemic, she took a really proactive but sensitive approach to tackling the issue of vaccine hesitancy. And I think we're going to be able to get some real insight into how and why this issue affects different patient populations differently, and to learn some practical tips on improving the situation. So welcome, Farzana.
Hello, Rhiannon. Thanks so much for having me.
Thank you for joining us. So to start with, who are the key communities that we're talking about here who might have lower rates of vaccine uptake?
So, lots of diverse communities, Rhiannon. I work in Newham in East London. We are probably one of the most diverse communities in the country. Over 70% BAME, but actually over 200 languages spoken. Some of the things I learnt when I decided to take a more proactive approach during the COVID vaccine rollout, the very first stages, I was finding that amongst my patients who weren't taking up the vaccine, I would say there was probably four groups, if I could group them, although there's more diversity than even that. There was my Black Africans, then there was my South Asians, my brown South Asians, my white Eastern Europeans, and then the fourth group were actually white British who had a lower socioeconomic profile, so were living in more poverty. And it's fascinating, perhaps we'll talk a bit more in detail about the reasons for each group, which were very different for each group. And that's just four groups that I've lumped them into. Actually, we have people from West Africa who are very different from Afro-Caribbean people. So it's quite complex. What I learned was that actually talking about health inequalities with just a BAME lens, for example, or just a poverty lens is better than not talking about it at all. But it is actually quite complex and nuanced.
Absolutely. And it sounds like lots of, intersecting issues as well with ethnicity and social deprivation. So can you tell us a bit about why you felt so strongly about the issue of vaccine hesitancy in the first place?
Yeah, of course, Rhiannon. So I ran a list of 5,000 patients. That's a smaller than average list. I think the average list size is now 10,000 for a GP practice in the country. And Newham sadly had the highest death rate in the country during the first wave of COVID. And we were finding that the people, Newham is a very young population, and my patients who were young for Newham. So out of my 5,000 patients, I only had 200 over 65-year-olds. But sadly, a lot of my COVID patients that were dying or were very seriously ill were from the BAME communities, particularly the South Asians and the Black communities. And it was very interesting and sad for me to see that these were the people who were more vulnerable because of genetics, because of other long-term conditions such as diabetes. And they were the people that I would say probably needed the vaccine more. And they were the ones that were taking it up less. So it was a true example of that thing I learned about in medical school 25 years ago, the inverse care law, that the people who need the treatment most were the ones that were not accessing it. And I was very concerned about this, like many GPs, when I had, in under 2 weeks, I had 6 deaths in a row of COVID. And that's unheard of for my list size and my population. We generally have not more than 2 deaths a year. So on a personal level, I felt I really wanted to do something. My numbers were small enough that I could. So I took it upon myself to actually phone personally about the 100 people, because at that time it was only for the over 65s, the 100 people who hadn't had their vaccine, because the 50% that had were all bar one Caucasian, and everybody who hadn't had their vaccine was from an ethnic minority, which was fascinating in itself.
So explain a bit more then about what you did. You said you called up the patients individually and chatted through with them what was making them reluctant to take the vaccine up?
Yeah, Rianne, so I'm quite a curious person. I'd say nosy probably, but I don't think that's a bad quality in a GP. And I wanted to understand why England, we were the first country in the world to have the COVID vaccine. It was free. Nobody needed to pay. I'm a British Bangladeshi. My father's a retired anaesthetist, 82, and he was telling me, he still lives up in Lancashire where I grew up. And he said, Farzana, we're so lucky in England because actually in Bangladesh, people can't afford their COVID vaccines. And I was thinking to myself, we're the first country in the world, we've got the vaccines, we're wanting to deliver them. What's the gap? What can I understand about this? So I thought, as a normal GP would do, let me ask. And some of the information I found was fascinating. Again, I'll probably group it into 4 bits. I did find that, particularly with my Black Africans, I had forgotten, or maybe it had never occurred to me, Rhiannon, that the people who were in their 80s, it was only their parents' or grandparents' generation that had seen slavery and that had actually seen or had stories of their grandparents being experimented on. I mean, that really happened. That's not a lie. And I think that historical information for them really led to a massive mistrust. And that was also echoed to them or confirmed to them by some of the wider stats we have that was not linked to vaccines, where we know that young Black men are more labelled with schizophrenia, even if they don't have it. Similarly with my Eastern European patients, because they tend to get more medication and more intervention, I find often in when they go back home. And the UK doesn't do that. So I think, again, it was stemming from a mistrust because the two healthcare systems do seem to be quite different, and they're able to, in real time, get healthcare advice from their countries of origin as well as England. Sometimes on a wider note, those messages are quite different. And that's why I think it led to, again, some mistrust of, I'm not going to take a vaccine that's new and the UK is the first country. I think I'd rather wait, and I'd rather wait to see what happens in my home country before I vaccinate my elderly relative. So I realized it was a very interesting sort of, if you like, social science data gathering, that all of these factors, because we're not just patients, we're human beings, that all of these factors were playing into the reason that they absolutely mistrusted many times the health professionals and what this new vaccine was, and also because there was such a lot of misinformation on social media. So I took the very simple approach of listening, and I wanted to make sure that they had their autonomy to be able to make their own decision rather than forcing anyone to take it, but making sure that they also had medical information. And I think one of my nicer stories was I had a patient who was 82 at the time, and my own mum would have been 82, but I lost my mum when I was 19, and I know her very well. And I said to her, what is your concern? She said, well, I'm really worried about it's a new drug. I'm worried about the long-term side effects. And because I know her, I giggled and I said, you're 82. If in 20 years' time you grow a second head, I'll chop it off for you, even though I'm not a surgeon. And we giggled about that, and it helped her get into perspective that actually her risk of getting COVID and, God forbid, dying was much higher than any potential side effect that could happen in 20 years. And because it's lovely to be a family GP and have a small list size, I said, my own mum isn't here. She died when she was 57, but if she was here, I would have wanted her to have it, and I'd like you to have it, even though you're not my mum. And her daughter rang the next week and said, I don't know what your doctor said, because I couldn't convince my mum to have it, but she went and had it. It made me remember the power of doctor-patient relationships and continuity. And that example, which was very early on when I was ringing, made me want to ring more patients. The second part, I think a lot of my BME patients, particularly women, Rhiannon, who were younger, so this was kind of when the vaccine program was rolled out to under 65s, there was definitely a real fear about it causing infertility. And again, I had a patient say to me, she said, being a South Asian Muslim woman, you will understand, doctor, that if there's even a 1% chance that I can't have children, I am not going to take this vaccine, because you know as well as I do that I would be shunned by my family. And I said, completely understand, I'm a mother of 2 who has polycystic ovaries, so I know what it's like to have some fertility and all the societal, cultural norms that are around that. And it was, again, fascinating, Rhiannon, because normally as medics as well, we're saying to people, don't have things when you're pregnant, don't have extra medication. But where flu vaccine, where COVID vaccine, where whooping cough pertussis vaccine is concerned, we're actively encouraging people to have those vaccinations. So that again taught me about how we give our messaging, and again putting risks in perspective, because actually if mummy has COVID and mummy's pregnant, then that's potentially very dangerous for an unborn baby as well, much more dangerous than having the COVID vaccine. So again, their worries were different. And I would say that my Caucasian patients who knew is an area of high deprivation, for a lot of them, it simply wasn't even that they were that against it. They were just thinking about how to earn money in COVID. People had lost their work in gyms, in hospitality. They were in 0 hours contracts. It wasn't the highest priority for them. So, like you said, the intersectionality, it's more than one thing going on. So, a melting pot of working in an area of high socioeconomic deprivation and different cultures, different health beliefs, and mistrust. So it was good to work out some of the problems, because only then could we start with solutions, as in listening and trying to give honest messaging. Yes, it's a new medication, absolutely, but actually, mRNA vaccines have been around for quite some time, and no vaccine comes onto the market unless it's been tested lots of times. And we know with COVID vaccine, don't we, Rhiannon, that rather than doing trials in sequential order, as many trials do, that they did a lot of people together, parallel, but still the safety aspect of it was still the same. And hearing things like that, I think, was really helpful for my patients. Many patients wondered if it was halal, a lot of my Muslim patients. And again, being able to answer those questions very honestly and saying we don't have all the answers, it was still a very new vaccine, I think helped build that trust.
It's interesting you mentioned fears around fertility, because I'd actually forgotten all of that right at the beginning of the pandemic, the fears around the vaccine impacting fertility. And we recently published a learning module on MIMS learning based on the Embrace reports. And one of the lessons taken from that was around encouraging vaccination, because, of course, people from minority ethnic communities were disproportionately affected by COVID, as you've said, when that intersected with pregnancy and how vulnerable pregnant women are to infections, like with flu and pertussis, and as well as COVID. That was a really key learning point that we drew out from that report, was around it being a kind of key facet of good antenatal care to really give the patients good information and accurate information, and really encourage them to take up those vaccinations.
Yeah, absolutely. And timely that you talk about that. UKSHA, I can never say it right, the UK Security Health Agency, have just published again that whooping cough is coming up. And again, it's about the messaging, because I know I felt this. My kids are 20 and 21 now, but I still worry about them. They don't even live with me. They're at university. But we all want the best for our baby, and we want the best for our unborn baby. And we think that putting something that's sort of foreign into our body is a dangerous thing. And sometimes the health messaging can be confusing, because yes, we don't want lots of medications being taken during pregnancy, but the exception to that is these vaccines, because we forget that actually, nearly every winter, a small number of women die of influenza. We think everybody's got flu, but actually influenza can be really dangerous. And when we're pregnant, we are in a more immunosuppressed state. We are more prone to infection. So I think it's about having those conversations, really, that this is about you and your health. And of course, your health absolutely directly affects baby's health, because baby's growing inside you.
Absolutely. I'm pleased that you mentioned actually the increasing rates that with whooping cough, and also recently measles was being talked about. And so I'm wondering, though, all these fascinating lessons that you learned from talking to your patients, do you feel like those lessons can be extrapolated to these other situations? So, specifically thinking about like sort of lingering fears that parents might have around the MMR vaccine for their children and that sort of thing?
Yeah, absolutely. I would say the ingredients are still the same. It's sort of listen, and I know it's hard. Health professionals are often busy, and I know our nurses do in practice a lot of this counselling as well, and it's busy. But there's no substitute for genuine listening, and listening without wanting to respond, and listening genuinely to somebody's concerns. So measles, mumps, rubella vaccine, of course, this is interesting for me, Rhiannon, because I became a GP. I qualified in 2001 in the height of the Andrew Wakefield report, which of course was since discredited. But I grew up in a time where, just as I'd become a GP, I'd had mum saying, I'm going to France to make sure I can get the single vaccines so that my child doesn't have autism, and I don't know why England won't give it. And of course, that was 22 years ago. And a lot of those people, toddlers at the time, have now become parents themselves, just like my children are 20 and 21, So I obviously chose to have my children vaccinated and was very keen on that. And thank God I did, because of course we forget that measles doesn't just kill babies, but actually it can kill young people, in university settings, in settings. So it is, sadly, measles rates have gone up, particularly in London and the Midlands. So I think we can certainly take some of the learning that I had with COVID and extrapolate that. And again, give people the correct information that actually, yes, this got a lot of attention, but there was absolutely no proven connection between autism and the MMR. And again, sadly, that if you do get complications of measles and you do get an encephalitis and your brain is inflamed, you're going to God forbid, die, or, have brain damage. This is much worse than any possible autism scare could be. So particularly in these days of social media, where people can get information from anywhere and we can't test it. We don't know whether what we're reading on WhatsApp or Twitter or Instagram is information that's correct or not. And that's why I think we have a really big job as health professionals to give the best information that we have, following the data, following the guidelines and following the evidence.
I'd like to pick up again then on you were talking, earlier about the benefit of your role as a family GP and really knowing your patients well. And I read in a previous blog that you'd written about the importance that you place on working with families, and particularly, that you feel that often mothers can have a really big influence across the family, particularly in sort of multi-generational households. So can you talk to me a bit more about that?
Yeah, so it's a giggle statement, but I think many women will understand this. So if your mum tells you to put your coat on, you put your coat on. So say like my son is 21 and he's in medical school himself up in Manchester, but I'll still say, oh, it's raining up there, isn't it? Where's your coat? And to still pacify me, even though he's an adult himself, he'll put it on. We sometimes forget the power that is within families, because as health professionals, of course, we can give our information and we can build those trusting relationships, but we're not in the family. And I found that particularly during COVID, if I could get the 30 to 50-year-old mummy on board that COVID vaccine is a good thing, she would then make sure that her husband dutifully went for his vaccines, her mum and dad went for her vaccines, his mum and dad went for their vaccines, and any children. So by talking to one person who held influence in the household, I was able to get 6-7 people vaccinated. And I think that's also the power of communities and the way I think, as a general point, the NHS needs to work. I mean, I'm in primary care, and I think we talk a lot, and our politicians talk a lot about prevention, and we know we've never seen so much obesity, and we've tried to stop smoking, and actually vaping has increased. So we've got a lot of public health issues, and solving a lot of public health issues is not going to be done just by the NHS and healthcare professionals. We need to really key in and work with, as partners, with people in the community, and not just community health leaders, but actually influential people such as women in their households. And it was interesting during COVID run that certainly where I work and over the country, we could see that a lot of COVID vaccines were given in places of sports centres, but also places of faith, in gurdwaras, in mosques, in churches, in synagogues. But one of the things that I also pointed out, being from a Muslim faith, is women don't have to go to mosque. We don't need to pray mosque. So we need to make sure that we're not missing the whole cohort of people as well, and that we're not just talking to just a number of people who are representing faith leaders, not everybody goes to mosque. So it's really quite nuanced, and thinking about who in the community and how many people can spread that sort of social activism, really. Like if I can speak to one mum, then maybe she'll talk to another mum, and she might talk to another mum. And that's how we're really going to key in to something like vaccination, because we know that we need herd immunity for something like measles, where if you and I have got our vaccines, Rhiannon, but actually 10 other people haven't, we've already gone down to 90%. That's below herd immunity. We need 95 out of 100 of us to have our vaccines. Otherwise, this virus is too clever. It's going to be circulating and none of us are safe. So unless we're all protected, none of us are protected.
Yeah, and actually, a fascinating kind of point on that. Speaking to our GP clinical advisor earlier on, he was talking about vaccine hesitancy and saying, in an average sized list, it might be that there's only 5, 6, 7 patients not being vaccinated, which pushes you below that sort of, is it 90-95% threshold or whatever you have for immunity. And if you're looking at big multi-generational families, it could be that those 5, 6, 7 people who are not being vaccinated are all from one family. So, even just convincing one person or talking to one person and reassuring them and giving them the advice, the information that they need to make a reasoned judgment could have a sort of ripple effect, I guess, on other people in the community.
Exactly that, Rhiannon. I mean, in a 5,000 list side, it's what your clinical advisor was saying. Absolutely, like with the MMR vaccines, we in Newham and in East London are struggling to hit our 95% targets, as many practices are in there. And of course, East London has had an upsurge of measles. But actually, if you look at each practice, as you say, it's about 6, 7 kids. And if each of us with those list sizes could do something or get extra support to help those children, it would push it up. Because as I say, it's not just about those children and their families, then everybody is at risk. So I think that's a really important point you make, which I think is sometimes overlooked and gets lost in the statistics, because those 5% need a lot more support to get their vaccines. The majority of people will have their vaccine, so it's not that hard to get to 70-80%, but actually it's that last bit and that last push, but that's the bit you need to have herd immunity and make sure that these viruses are not, coming up. It will be a tragedy to see these Victorian illnesses making a comeback as they are, sadly.
I really love what you've been talking about in terms of community, and you've talked about the complexities and the kind of cultural sensitivities. And of course, it's not no one GP can fully understand all of the issues faced by the different communities that they serve or the different kind of cultural sensitivities. But it's like you said, it's really about listening to your patients and finding out from them what are their concerns and what can you do to allay their fears, I suppose. And on that note, we know there's various national programs in the UK to address inequalities in vaccine uptake. But have you got any sort of practical tips then that the listeners to our podcast could take forward kind of on a local level into their practice if they want to try and tackle this?
I think for my very busy GP colleagues and practice nurse colleagues and people in practice where they've got so much to do as well as get their vaccine coverage, I'd say for me, I try and keep things simple. I can't remember lots of things, so just 3 things. First of all, being aware. For me, I made that connection that, gosh, these are the people that need the COVID vaccine most, and these are the people that are dying most. So being aware, because it's easy to forget simple things when we've got a million things to do as GPs. When you're firefighting and you've got 25 patients to see in a clinic, it's hard to step back. So to acknowledge that, maybe there is a connection, or there's something I can do. And then to think about what you can do. Like you said, Rhiannon, people are busy. One GP can't do everything, but one GP can do something. So I think it's a Mother Teresa quote where she said, if you can't feed 100 people, feed one. So if you can't ring all your list, that's fine. Maybe ring one, and who knows, that one might tell another one. And my third point would be following from that. So acknowledge it, try and just give yourself a little bit of time to reflect, to think, what is going on here? Just like I made a very simple connection, but it did take me time to make the connection that the ones that needed the vaccine and the ones that needed it most weren't getting it. Then do what you can Don't try and solve all the world's problems, but do what you can. Maybe 1-2 phone calls, or getting your nurse to make 1-2 phone calls, or getting your admin to make 1-2 phone calls, and then see if you can use your community to do the ripple effect. As you said, when you're vaccinating that child and mom says, oh, I'm so glad I did come. Oh, do you want to tell your friend then? Tell anybody that you see at the school gate, because that's going to be the power of community that will deal with public health issues such as vaccines. And let's not forget and keep celebrating with our communities and ourselves that apart from clean water, and antibiotics, vaccines have been the biggest game changer that we've seen this century, apart from clean water and antibiotics. And that's why most of us aren't dying of childhood illnesses.
Thank you so much for that fascinating discussion, Farzana. I've certainly learnt a lot there, and I think that's going to have left our listeners with a lot of things to reflect on and some real practical points that they can take forward. We'll be back next week, and we look forward to seeing you then. Bye for now.